All right, greetings everyone. Let's jump into some heavy stuff here. This is going to seem a little overwhelming at the beginning, but you're going to see this quite a bit, and it's really important for you to grasp these concepts early. So if you don't have an anatomy and physiology course or two or any background in A&P, you'll see that throughout the course you'll just need to kind of refresh yourself and get yourself up to speed. So I'll provide these little videos. There's also a tremendous amount of stuff that's available online. I'll also put a couple of my favorites so that you have easy access. You don't have to waste time looking for stuff. The other thing is you have access to a couple anatomy and physiology books. I've posted them online. They're in PDF. They're searchable. They have graphics. So there are resources for you. If you need help, get together with somebody else in the class and study together. This is certainly not above anybody in this class. This is at your level. It's just something new, so don't despair. In any case, let's talk about electrolyte regulation, and certainly there are more electrolytes than just the three that are listed. Just these three happen to be the most important in my estimation, and they happen to be the most relevant to the pre-hospital setting. So all of this stuff, as you see, we've tried to tailor it to an EMS-focused or an EMS-oriented approach, because there's little value in you knowing the complexities of internal medicine if it's something that you're not going to use every day. So this is stuff that you will absolutely use every day. This is stuff that you will see in patients that have disease processes. They'll have dysregulation or the lack of regulation of these three things, and you can actually impact these things. You can give medications to change the way calcium moves in our body. You can give medications that force potassium out of the body, and certainly we can impact sodium as well. We have drugs that block sodium channels. So these are really, really important. So don't dismiss the importance of this stuff. Just eat the elephant one bite at a time. And if you have questions, of course, bring them into class. We'll deal with them there. So we're going to talk about how the body regulates calcium, potassium, and sodium, not necessarily in that order, but that's what we're going to talk about. So before we can really deal with electrolyte regulation, we have to understand a little bit about how the kidney functions. So we're going to look at the functional unit of the kidney, which is called the nephron. And the nephron is where it's the business end of the kidney. It's what does all the work. So inside the kidney, we have millions and millions of nephrons, excuse me, and they're all doing this business for us of filtration and reabsorption and secretion. So these are the three things that kidneys do. The kidneys, they filter all of the blood for us, essentially. They secrete things, meaning that they can make certain molecules and put them back into our blood. And then, of course, they can reabsorb things so that we can maintain the things that we need, like glucose, for example. Your body needs to get that glucose back into its system. We don't want to just pee glucose out. That wouldn't make any sense. Your body works so hard to get that glucose from whatever it is you ate. You eat a cookie and you get glucose out of it. It's pretty remarkable. So your body's put in a ton of energy. It's got a lot invested in it, and so it's going to be able to selectively decide what things it should keep, what things it needs to get rid of because they're either toxic or they're in excess quantity in your body, and it does that with tremendous efficiency. So this is the nephron, this whole piece that's in yellow, essentially, starting with this little guy right here. All right, this is kind of the division. So this is an arteriole that's coming in, and this little guy that's here, I'm going to change colors here. This little guy that's here where it says glomerulus, this is actually, this is where the interface exists between blood and the first piece of filtration that takes place. So you don't need to necessarily know all these fancy terms. I want to whet your palate with it. I'll tell you what you need to know. This little guy here that looks like a C is called Bowman's capsule, and Bowman's capsule is the entity of the nephron that makes the interface with the little arterioles and the little capillaries coming from the blood vessels from the body into the nephron itself. And this is where we have the beginning of filtration taking place. As you know, just like making coffee, filtration is based on the size of the pores in the filter and the size of the molecules that are surrounding the filter. So if the pore size is 1, everything that's greater than 1 doesn't make it through the pores. It continues on into the blood. Everything that's less than size 1 goes into Bowman's capsule. Things such as potassium and water and sodium and calcium and urea and all these other things that exist in our blood, they all get into Bowman's capsule here, and they enter what is called the urinary tubule, and that's this yellow guy here. So this urinary tubule is the path through which all of the fluid that has been filtered through Bowman's capsule is going to end up in, and from there, the nephron is then going to work its magic to selectively take the things out of the urinary tubule and dump them back into our blood, or leave them in the urinary tubule and send them off to the bladder so you can pee it out. So this is a pretty remarkable thing, and essentially the filtration piece of it, I think, is pretty simple. What's not so simple is the next piece, and we're going to see that concentration gradients play an important role here. So it's important to recall that if you have something in high concentration, so if you have 100 pieces of something on one side and you have a semi-permeable membrane and you have 10 pieces of that same item on the other side, the tendency is for equilibrium to take place. So these guys are going to want to cross down here. They're going to want to move down their concentration gradient such that at the end they end up with 50 pieces and 50 pieces. And it doesn't matter what those pieces are. So the only limitation here is the size of the pores or the size of the channels or openings that exist in this membrane. If they are big enough to accommodate movement of the molecule, then movement of the molecule will take place and equilibrium will take place. So this is essentially what the kidney does. The kidney establishes gradients, and it establishes gradients of things such as calcium and potassium and sodium and a bunch of other things, and it establishes gradients based on the existing number of molecules inside the urinary tubule, so in here, versus the surrounding area of concentration. So you're going to see here that wrapped around tightly or wrapped around in parallel next to the urinary tubule, there are a bunch of purple guys right here, and these little purple guys are little arterioles and little capillaries. They're called peritubular, peri, around, tubular, the tubule, the tube. And these guys, peritubular capillaries, are what allows the nephron to establish concentration gradients between the filtrate, the stuff that's inside the urinary tubule, and the stuff, the blood, that's inside the arterioles and the capillaries that surround it. So essentially the kidney is just this incredibly efficient way and this incredibly sophisticated mechanism of establishing gradients in such a fashion that it allows us to keep the things we need and get rid of things that we don't need. So a couple other pieces here. So this is called the proximal, the early, convoluted. It's convoluted because look how shapely it is. Tubule. So the proximal convoluted tubule essentially starts from Bowman's capsule and ends at the beginning of the loop of Henle. So the loop of Henle is this green guy here, and it goes all the way up to here, and this is the loop of Henle. So loop of Henle is all this green stuff, all this is the loop of Henle. And again, this is just where concentration gradients are established for very precise movement of different things. Lastly, we have the distal convoluted tubule. That's all this guy here. Again, distal means far away. Convoluted means that it's shapely, it's all coiled up, and then tubule refers to the tube. And then last but not least, we have the collecting duct or collecting tubule, and this will eventually lead out to the ureters and down to the bladder, and that's what you get rid of. So everything that's inside the yellow is something that's eventually going to end up in the bladder if it stays in the urinary tubule. All right, so let's keep moving here a little bit further so that you can continue to see the miracle here and how pretty cool this kidney is. So you're going to see that the pictures are going to start. They're going to start including a little bit more stuff. And so again, let's start with the basics. This is where we had the arteriole that comes in. This is Bowman's capsule. This is where the filtration takes place, and everything dumps into this little proximal convoluted tubule. That's this guy here. And you'll see that as we start getting deeper into the nephron itself, you'll see that the osmolarity, the concentration of stuff, is also getting greater. So it's getting greater because we are losing water to the surrounding area. So this is the little peritubular capillaries, and they are right next to the loop of Henle and the tubules and everything else. And as the fluid, the filtrate, is going down the proximal convoluted tubule, down the loop of Henle, these cells that make up the loop of Henle are very permeable to water, and they are impermeable, they're not permeable to things such as potassium, sodium, calcium, urea, and all the other things that we don't want to keep in our body. So as these cells, they're impermeable to everything but water, essentially, water starts to leak out. As water starts to leak out, we get a concentrated filtrate. That means that the concentration, the osmolarity of this filtrate is increasing as you move down into the loop of Henle, and the reason for that is because of the permeability of the cells that make up the loop of Henle. So pretty cool. All right, so now as you start moving back up the ascending, the moving up loop of Henle, well, the permeability of these cells is the same, but you'll notice that we have these additional channels in here, and these are actually transporters. So these are mechanisms that use energy, and they use energy to selectively move things in the right direction. So they're co-transporters, and they're going to take these molecules and they're going to start moving them in a direction that we want. So we're going to continue to move forward, and you'll see that in the distal convoluted tubule and in the collecting ducts, we have this additional thing now, and we have another pump. It just happens to be that it's regulated by aldosterone, and we're going to talk about aldosterone in a second, but I want you to think about aldosterone as the sodium saver. So wherever there's aldosterone, there's going to be a collection of sodium. Wherever there's sodium, there's going to be water. So you know if you eat a heavy salt-laden meal that you're going to be really thirsty, and the reason for that is the more salt you have in your body, the more water your body's going to want to retain. So this is a pretty cool system. It uses some pretty sophisticated mechanisms, but the reality is it's a pretty simple concept. It's concentration gradients and the use of energy to move items against concentration gradients in certain instances. All right, so I think enough with this slide. You can certainly come back and review some of this stuff, and we're going to see this a lot this semester, right? Because we're going to talk a lot about this. Now, I apologize for the lack of clarity on this picture, but in the absence of drawing it myself, this is the closest thing that I could come up with, and it'll work for our purposes. This is what I want to illustrate with this. I want to illustrate that when the arteriole comes in here into Bowman's capsule, into the glomerulus. This is the glomerulus here, and this is Bowman's capsule here. When it comes into this area, the first thing that happens is we get filtration, and I mentioned that earlier, but I want to keep pointing that out so you have repeated exposure to it. So all of this stuff that's in this little arteriole, all of the things that can be filtered and that can go through this little filter ends up in this tubule. All right, so filtration takes place at the very beginning. At the very beginning of the nephron, we dump everything into the collection tubule here, into the proximal tubule, and then we're going to selectively decide what to do with it. All right, so as you see in the proximal convoluted tubule, there are certain things that are going to be reabsorbed, like glucose is one of them. We worked all that time and spent all that energy getting glucose into the body. Well, it does filter into the proximal tubule, and then very, very quickly it gets reabsorbed into the peritubular capillaries, and the reason for that is this. Remember, it's all about concentration gradients. So if I take this arteriole full of glucose and I dump all the glucose into the proximal tubule, now when I look at this area of the arteriole, there is less glucose inside the arteriole than there is inside the tubule. As a result, we've established a concentration gradient, and glucose is then reabsorbed back into the blood by way of the peritubular capillaries. All right, same thing happens here. All right, so sodium chloride and potassium, calcium, all this stuff. So we start to reabsorb here. So loop of Henle is designed to reabsorb things from the filtrate that we really need back in our body. And again, it's all based on either a concentration gradient or an active transporter that's going to dump it back into there. All right, now here's the thing. There are some areas where we have secretion that takes place, and secretion means that we're going to move something from the lumen of the blood, so in other words, the peritubular capillary, back into the collecting ducts or back into the urinary tubule itself. So this is just a graphic illustration of the different movements. You certainly don't need to study this. I just want you to have a general understanding of concentration gradients and how that affects the movement of certain things. All right, so now let's keep moving forward here. Now that we've talked a little bit about that, we're going to say, okay, well, let's look at some of this stuff now and figure out where exactly potassium, for example, is regulated. Well, potassium and sodium and calcium, both heavily regulated, in fact, almost exclusively regulated by the nephron, by the kidneys. So anytime you have a patient with kidney disorder, you could have electrolyte imbalances, and I think you've seen that in your practice. All right, so when we have a normal functioning kidney, here's what happens. What happens is we get the filtrate, it dumps into the urinary tubule. There are some things that get reabsorbed, such as water and ions like potassium, like calcium, like chloride, like sodium. All these things start to get reabsorbed into the system. And this has to do with concentration gradients and permeability of these cells. So potassium regulation happens in several spots. It'll happen a little bit in proximal convoluted tubule, it happens in the loop of Henle, and it also happens in the distal convoluted tubule. So anytime we impact the permeability of these cells, or we impact the concentration gradient of these cells, that's going to impact the ability of the nephron to either maintain or get rid of certain things. So let's take a look, for example, at a diuretic that you're going to become very familiar with, and that is the loop diuretic Lasix or furosemide. So when you look here at number 3, if you look at number 3, you'll see that this is the loop of Henle. It starts here, it ends there. This is the loop, and it kind of goes that way. All right, this is the blood flow, path of blood through the loop of Henle. And you'll see that in the loop of Henle, when we administer a drug like a loop diuretic, those things are said to be non-potassium sparing. And the reason is that it negatively impacts the co-transporter that exists here, and it also impacts the permeability of the cells of the ascending loop of Henle, such that we end up getting the inability to reabsorb the potassium from the filtrate back into the blood vessels that are surrounding it, and as a result, we end up peeing out potassium. All right, so there's a higher concentration of potassium that exists in the urine as a result of this drug. So that can be problematic. And you'll see, we'll talk more about this stuff. Atrial natriuretic peptide, we'll talk about that in a few weeks. And aldosterone, I've already mentioned, but you'll see these things all impact permeability of different areas of the nephron. And the area of the nephron that's impacted is directly related to the specific electrolyte or specific ion that will ultimately be lost or be withheld at the level of the nephron, and so these are important concepts for you to have an understanding of. All right, so let's take a look at sodium. You're going to see this a lot. You're going to come back and see this a lot. What I don't want you to do is try to memorize this. There's no point in doing that. What I want to draw your attention to now with respect to the sodium regulation is I want you to start right here. We're going to start with the posterior pituitary. All right, we're going to forget all this mess for now. We're not going to deal with any of this mess for now. All right, this all comes later. But what I want you to see here is that if the posterior pituitary and the kidneys are working together here, so there are methods of regulation that involve multiple body systems at the same time. Essentially what happens is this. So if in fact we have too much sodium in the body, if we have too much sodium, so high sodium in the body, the posterior pituitary is going to be told about that by the brain and some other mechanisms, which we'll get to in a little bit, and it's going to tell the posterior pituitary to stop releasing antidiuretic hormone. So it inhibits the release of antidiuretic hormone. So antidiuretic hormone makes you stop peeing. If you inhibit antidiuretic hormone, that means you pee more. So ADH, antidiuretic hormone, decreases urine production. If you cancel ADH, if you inhibit ADH, then you get an increase in urine production. All right, so let's take a look at this. So ADH comes out. ADH says, whoa, hey, tell the kidneys, you guys should stop reabsorbing sodium. In other words, you should increase the amount of sodium that gets put into the urine. Aldosterone is also inhibited in this. And remember we said that aldosterone is the sodium saver. So the sodium saver aldosterone is eliminated essentially. ADH is inhibited. So we go to the kidneys and we're now going to change the permeability of the cells in the nephron such that they are prevented from reabsorbing sodium. Well, whenever you have sodium that's not reabsorbed, meaning that you leave sodium in a compartment, water is going to follow that. So picture this. Here's your little nephron guy. All right, I'm not a great drawer, but I'm going to do the best I can. Here's your little nephron guy, and so this is where urine is. Urine is inside this thing, all right? So we're going to take ADH, which normally comes in here and changes the permeability of these cells, and aldosterone, which changes the permeability of these cells, which normally allows sodium to come out of the urine. Well, now we're going to prevent those chemicals from showing up. That means that sodium is going to be inside the filtrate. As a result, water is going to want to move inside as well. And if we put water and sodium inside the urine, we are going to get an increase in urine production and a decrease of blood volume. All right, so this looks like a busy slide. There's a lot of stuff on here. Maybe some of it's new. You don't have to remember everything. What I do want you to be familiar with is this. If you have too much sodium, you are going to inhibit aldosterone. I want you to know that aldosterone is the sodium saver. So anything that has to do with sodium, I want you to think aldosterone. All right, so aldosterone, sodium saver. If you inhibit aldosterone, you prevent aldosterone, that means that you're going to get rid of sodium. If you get rid of sodium, that means you're going to get rid of water. Right? So think about sodium and water, they're always hand in hand. All right, let's take a look at calcium now. Enough about those guys. Let's take a look at calcium. Again, I don't want you to memorize all of these things. You don't need to worry about concentrations and the numbers for now. This is what I want you to think about. I want you to think about this. So if you have calcium levels that are rising, right? Calcium levels that are rising in the system. One of the things that regulates that is the thyroid gland. So the thyroid gland releases a chemical called calcitonin. And calcitonin is a chemical that deposits calcium into the bone tissue. So increase in calcium, thyroid gland responds by releasing calcitonin. Calcitonin, when it's in the blood, in the presence of calcium, makes calcium salts deposit inside bone, and you have a resolution of the hypercalcemia, or the elevated calcium levels. All right, conversely, when the calcium levels are low or they're falling, then the parathyroid hormones, that's these little guys here, the four little parathyroid hormones that lie on the back side of the thyroid gland. Parathyroid glands, they released parathyroid hormone, all right? And parathyroid hormone is something that goes to the bone, and it actually causes calcium to come out of the bone and back into the blood. All right, so falling blood levels of calcium, parathyroid hormone, increase in blood. If there's an increase in blood too much, thyroid gland releases calcitonin, causes deposition or deposits of calcium back into the bone. So what do you really need to know from this slide? You need to know about calcitonin. Calcitonin is used to reduce circulating levels of calcium. The other one that you need to know is parathyroid hormone. Parathyroid hormone elevates or increases circulating calcium volume. All right, so I realize there's a lot of information in these slides. I don't want you to sweat all this stuff. Just try to focus on the few things that I mentioned, a little bit about concentration gradients and the like, have an understanding of calcitonin and PTH and where they come from, and I think you're going to be good to go. Remember, in a little while here, we're going to start introducing the disease processes. So we'll talk about things like what happens when somebody has a thyroid disorder or a parathyroid disorder. Well, when we get to that, I want you to start thinking, holy cow, thyroid disorders might mean that they're going to be hyper or hypocalcemic. So thyroid, I like to think of the thyroid with respect to the electrolytes as the regulator of calcium. All right? When you talk about diseases of the kidneys, you should think about sodium and potassium regulation problems. So we're going to introduce all of those, no worries. And if you have any questions, as always, bring them to class and we'll deal with them there. Stay tuned.